And all. So, welcome to yet another edition of Vijaya Diagnostic Center Educational Webinar Series. So, today in this series, we shall be presenting for protein electrophoresis, serum protein electrophoresis, which will be presented by my colleague, Dr. S.G. Hatim. So, myself, Dr. Jnankumar Chaudhuri, I am Senior Consultant and HOD Biochemistry here at Vijaya Diagnostic Center, Hyderabad. And I'm here to, I'm pleased to announce that my colleague, Dr. S.G. Hatim, who is Senior Consultant Biochemist here at Vijaya Diagnostic Center, Himayatnagar, and he will be presenting this topic on serum protein electrophoresis. So Dr. Hatim has completed his MD Biochemistry in 2013 from Osmania Medical College and has 12 years of experience in clinical lab. So today he will be presenting this topic, and without any further delay, I hand it over to him. So before that, I'd like to announce that you can prepare for some questions which we can discuss. So we can take the questions after this presentation is over. So please type the questions in the control panel in front of you, in your system, and we shall take the questions at the end of this presentation for discussion. So without any further delay, I hand it over to Dr. Hatim. Dr. Hatim, please.
Thank you so much, sir. Okay, good evening, everyone. I'm Dr. Syed Wausali Hatim, Senior Consultant Biochemist at Vijaya Diagnostic Center, Himayatnagar branch. So today the topic in webinar series is protein electrophoresis. Yes. So in protein electrophoresis, we'll be discussing the basic aspects of what is protein electrophoresis, how it is done, and what are the different types of protein electrophoresis, and what are its implications, where we use it, and what is the technique, by which technique we are doing protein electrophoresis at Vijaya Diagnostic Center, and how we report the protein electrophoresis. So as you know, it's a separation technique where we separate and analyze proteins based on the electric charge, size, and shape. So usually we are doing here in serum. So it can be done in urine, CSF, and other body fluids. But here in Vijaya Diagnostic Center, we do in serum, that is blood. So serum protein electrophoresis, basically, which will help in diagnosis and monitoring of various diseases, particularly the diseases which are affecting the plasma cells. Coming to the principle, basically proteins are placed in a gel electrophoresis, and in capillary system in capillary electrophoresis. So whenever we apply the serum sample in a gel or a capillary system, in that equipment, we give an electric current. So electric current is applied, which causes proteins to migrate at different speeds based on their charge and size. Okay. So because of this electric current and this mobility, there creates a peak or a band. Okay. After the staining technique. Basically, what's the purpose of serum protein electrophoresis? Why we do electrophoresis? So there are the different conditions where we can diagnose, or at least we can help in diagnosis of these kind of diseases. So most importantly, monoclonal gammopathies, so which include multiple myeloma, Waldenström from macroglobulinemia, and polyclonal gammopathies, where different infections like chronic infections, autoimmune diseases, liver diseases. Here we see basically broad range of changes in gamma region, and some hypogammaglobulinemias where gamma globulin fractions are decreased. And by this electrophoresis, we can diagnose or come to a diagnosis in malnutrition, liver diseases, and in nephrotic syndrome also, where we see significant changes in the albumin. And by in acute phase reactions, where in alpha 1 and alpha 2, there are some changes like increase in their fractions. So we can come to some diagnosis with help of this protein electrophoresis. As I said, because of running these samples by electrophoresis, we can come to some diagnosis like pathological conditions associated with inflammation, hepatitis, cirrhosis, and nephrotic syndrome. And some monoclonal gammopathies like multiple myeloma, along with some specific clinical signs and symptoms. So along with this electrophorogram, where we see monoclonal changes, we should be having some clinical signs in the patient to say that the patient is having multiple myeloma. And it also allows an early detection of asymptomatic myelomas and to monitor some evolution of malignant disease or follow-up of the efficiency of immunosuppressive treatment in the malignancy patients. Coming to the types of protein electrophoresis. First, it is serum protein electrophoresis, where we run the serum samples, where the proteins are separated into albumin, alpha 1, and gamma fraction, alpha 1 and alpha 2, and beta gamma fractions. So basically, it is useful in the diagnosis of multiple myeloma, chronic infections, liver diseases, and nephrotic syndrome. So we can do in urine also. So where we detect abnormal proteins in urine, like Benz-Jones proteins in multiple myeloma. In CSF. So if you run CSF sample, the oligoclonal bands we see in CSF, especially in multiple sclerosis. Coming to next type, it is agarose gel electrophoresis, which was the traditional method previously used. So where there is migration of proteins in the agarose gel. Now the modern and automated method where most of the labs are using is capillary electrophoresis, where our Vijaya Diagnostic Center also, we are running serum protein electrophoresis by capillary electrophoresis. So we use narrow capillaries to detect proteins by absorption. Coming to immunotyping or immunofixation electrophoresis. It is a combination of electrophoresis and immunoprecipitation. So after running electrophoresis, to know which type of heavy chain or which type of light chain is there, like IgG kappa or IgG lambda or IgA lambda or IgM lambda something. To identify, to specify one immunoglobulin, we use immunotyping. The other type of electrophoresis is isoelectrophoresis. So here separation of proteins is based on isoelectric point. It is very high resolution. So mostly in clinical setups, it is not used, but common in research purposes. So by CSF studies in multiple sclerosis, it is useful. The next type of electrophoresis is SDS phase. So sodium dodecyl sulfate, polyacrylamide gel electrophoresis. So again, it is a research purpose. So mostly in the research field, it is used. So where the separation is based on the molecular weight of a compound. So after denaturating with SDS. So as I said, not used in clinical labs routinely, but for research purposes, it is used. So coming to the technique, what we are doing here in Vijaya Diagnostic Center, that is capillary electrophoresis. So what is the principle here? What we use the principle is. So again, as I said, we apply the electric current after giving the sample. So because of this high voltage of electricity, there is migration of charged particles depending on the different speeds due to their electrophoretic mobility and electroosmotic flow. So because of these separations, we can quantify and analyze different types of proteins. So this diagram shows the principle. So where is the injection point of protein? What is the flow of electric field? And you can see the electroendoosmotic flow also. The cathode and the anode. This is the place where injection of protein occurs. the separation occurs, the flow of electric field. Because of the charge, particle size, different speeds, these proteins migrate, and ultimately we get a electrophoregram like this. So this is the graph what we get after running the samples by capillary electrophoresis. So there you can see different fractions of proteins. So basically albumins and globulins. So albumin, and in globulins we have different fractions like alpha 1, alpha 2, beta 1, beta 2, and gamma. So the graph what is seen here is the normal graph. This is how a normal electrophoretic pattern appears when we run a normal sample. So again, this is the normal pattern showing different protein fractions. So along with these alpha 1, alpha 2, beta 1, beta 2, gamma, we have certain proteins in the serum where similar charges. So sometimes in these regions, we can get an additional fraction or additional peak. So sometimes we get additional peak in alpha 1 because of alpha 1 antitrypsin. So alpha 2 microglobulin or haptoglobulin. In beta 1 also, we can get sometimes the peaks or bands because of transferrin. So these are the different proteins which can get reflected when we run the serum sample. And in beta 2, C3, C4 complexes and IgA, whereas in gamma, IgG, IgM, IgD, IgE, and CRP. So these are the several proteins which can get reflected in a electrophoretic pattern also. Now coming to how we see the graph and how we quantify and how we come to know that this fraction is high or this fraction is low by seeing the electrophotogram. This is the screenshot of the instrument what we are using here. So that is Sevilla minicap. So there we can see on the left side, we have the percentage, all the protein fractions and its percentages and concentrations. So it will clearly depict less than or more than symbols. And also if we keep a cursor here, we can show the normal ranges also. So by this, you can say whether the fraction is increased or decreased. Or you can see the pattern also in the graph, the arrows what you have shown. So if you can see, albumin is decreased here. So this albumin is decreased, we can report. So likewise, alpha 1 and alpha 2 are increased. So by just seeing this pattern, we cannot say that it is increased or decreased unless it is very significantly increased. If it is fractionally increased, we need to see the concentrations and the percentages here. So most probably the concentrations we report. So if the concentrations are high or low, we report likewise. Or if you want to see the slide also, this is the slide where we can see this is albumin, alpha 1, alpha 2, beta 1, beta 2, and gamma. So this is the slide and this is the graph. And these are the concentrations. So by seeing these concentrations and seeing this slide and this pattern, we report. So this till now what you are seeing is a normal thing. We'll see now some pathological conditions. So these diagram depicts various conditions, various diseases where different fractions are increased or decreased. The left side, you can see all these are the different conditions, and these are the protein fractions what we are running, what we are getting in electrophoresis. So suppose in acute inflammation, usually albumin will be decreased, alpha 1, alpha 2 will be increased. In chronic inflammation, most of the time albumin will be decreased, alpha 1, alpha 2, and beta and gamma also will be increased. So likewise, in hypergamma globulin, as you can see, gamma globulin will be increased. In liver cirrhosis, usually because liver damage is there, so albumin is produced in liver. So definitely albumin will be decreased, whereas definitely gamma will be increased because most of the time cirrhosis, it's a chronic infection. So in chronic infections, we see hypergamma-globulin. Next, nephrotic syndrome. Because there is protein loss, proteinuria, there is decrease in total protein, albumin. And alpha-2 fraction is increased because alpha-2 macroglobulin will be get reflected in that, and gamma globulin will be decreased. So likewise, different conditions where different fractions you can see in this diagram. So individually, if we come start with acute inflammation, so how the pattern looks in acute inflammation. So this is the electrophoresis where you can see usually on the left side, if you can see the concentration wise, in acute inflammation, albumin will be decreased. So this is decrease in albumin and increase in alpha 1 and alpha 2. So suppose if you are seeing one pattern and you want to report it, so basically with the help of these concentrations also, you can report. So albumin is decreased and alpha 1, alpha 2 are increased, and the rest of the fractions, if you see, there are no additional fractions, and this gamma pattern also, there is no disturbance or distortion. Usually this is the normal pattern, what we call it as Gaussian pattern of gamma. So there is no disturbance here, there is no peak, there is no increase, nothing, there is no additional fractions. So only these parameters with the help of these concentrations are increased. So this can be an acute inflammatory pattern. Coming to chronic inflammation, there you can see clearly the gamma, there is peak. So compared to acute inflammation, it is slightly normal, and this is definitely increased. So how much it is increased, we can see here with the concentration. So here albumin is decreased, alpha 1, alpha 2, beta 2, and gamma fractions are increased. So this is the pattern of chronic inflammatory condition. So any chronic inflammatory condition, if you want to report, usually these are the representations. So coming to nephrotic syndrome. So is the disease, there is proteinuria, significant proteinuria. So definitely there is loss of protein. So decrease in albumin and alpha-1 globulin, increase in alpha-2 globulins. So this is the pattern you can see. So clearly we can see there is an increase in peak of alpha-2. So in nephrotic syndrome. And this beta gamma region, definitely there is some decrease. So in concentration wise also, if you can see, albumin is significantly decreased because of loss of protein, and alpha 2 is increased here, and gamma will be decreased. So this is nephrotic syndrome. Coming to cirrhotic profile, so liver condition, again there is decrease of albumin and decrease in alpha 1 and alpha 2 globulins. But there is one significant representation here, that is polyclonal increase with beta and gamma bridging. So this is cirrhotic profile. Here if you can see the fractions, the albumin concentration is decreased, and beta 2 and gamma are increased, and this is the bridge pattern. If at all you see any kind of these bridging between beta and gamma, then it will be a cirrhotic profile. Along with the other parameters you have to see in LFT, the liver enzymes, albumin concentration, and everything. So coming to hypogamma-globulin, so that is decrease in polyclonal immunoglobulins in gamma region. So it is associated with partial or total immunodeficiency, immunosuppressive treatment, pre-light chain disease, or non-secreting myeloma. The presentation will be like this. You can clearly see the gamma globulin region. It is significantly decreased, and you see the concentrations also, it will be decreased. So this is hypogamma-globulinemia. Coming to hypergamma-globulinemia, the opposite of that, increase of polyclonal immunoglobulins in gamma regions. So conditions will be inflammation, cirrhosis, and subacute and chronic infections. So this will be the presentation. Clearly there is polyclonal increase. So this gamma region, you can see the peak. It's not a peak, but there is significant increase. So concentration wise also there will be increase. So coming to monoclonal gammopathies, how we see the electrophoretic pattern. So this is the normal plasmacytes. This is the normal pattern you can see on the right side. So whenever there is malignant transformation, that means one plasma cell, if it is malignantly transforming, it is multiplying its the count. There you can see monoclonal immunoglobulins. So the picture will be like this in the electrophoresis. There will be a peak in the gamma region. So upwards you can see the normal pattern, and whenever there is malignant transformation, this will be the pattern. So where do we see these monoclonal immunoglobulins increased? So symptomatic and asymptomatic. Symptomatic are the multiple myeloma most common and other diseases. The asymptomatic small ring myeloma and MGUS, monoclonal gammopathies of undetermined significance. So how do we classify this? So based on the M protein concentration. So concentration wise, if you see, it will be less than 3 gram per DL in MGUS, more than 3 in small ring myeloma, and there is no limit in multiple myeloma. It can be more than 3 depending on the severity of disease. And cloning, the bone marrow cells, how much they will clone. It is less than 10 in MGUS, more than 10 in both small ring and multiple myeloma. End organ damage, definitely in multiple myeloma, it will be there compared to other two conditions. Along with these above findings, there should be some 2 criteria to fulfill to see that it is multiple myeloma. So the patient should have hypercalcemia, renal insufficiency, anemia, and lytic bone lesion to diagnose multiple myeloma. Now coming to position of monoclonal immunoglobulin. So usually we see that monoclonal peak in the gamma region, but it is possible that we can see the peaks in different regions also. This is the strong monoclonal peak you can see in the gamma region. So definitely this could be multiple myeloma along with the other criteria to be fulfilled. In concentration wise, if you see, the gamma globulin is increased. So it's a strong monoclonal peak. So how to know what type of heavy chain or light chain it is? We need to ask the patient to undergo immunofixation or immunotyping to confirm which type of immunoglobulin it is or free light chain it. This is one more case where you can see a monoclonal peak in the gamma region. So here also complementary immunofixation or immunotyping is required to confirm a heavy and light chain pattern. Sometimes we see these kind of graphs also. There you can see the gamma. It's not smooth here. There is, you can see some distortion here. So this could be an interference also, but this could be one weak distortion or some starting point or the relapse of some myeloma. So monoclonal peak can be seen in gamma region. Here also to confirm whether it is an interference or not, or definitely which type of immunoglobulin and which type of heavy and light chain is there. You need to ask the patient to undergo immunofixation or immunotyping. The one more case where you can see all the other fractions look normal. The concentration wise also they are normal, but the gamma region, the normal pattern is lost. There is some distortion, though this could be also one monoclonal immunoglobulin. So again, patient has to undergo immunofixation or immunotyping. This is one more case of again monoclonal gammopathy. So here the normal Gaussian pattern of gamma globulin is lost. So gamma fraction is not normal. You can see one single peak along with the other clones are decreased because there is decrease in concentration also. So hypogammaglobulinemia with a weak monoclonal immunoglobulin. So again, to confirm the heavy and light chain pattern, we need to ask the patient to undergo immunofixation or immunotype. So sometimes we get monoclonal peak not in the gamma region. So here you can see there is a peak in the beta region also. And concentration wise also, if you see, there is increase in concentration of beta 2 globulin. So to confirm whether it is an interference or actually it is a monoclonal peak, we again need to run the sample for immunofixation or immunotyping. If the interference is there, definitely it won't react with the anti-sera and we don't get any pattern. If it is a monoclonal peak, definitely we can see immunosubtraction in immunotyping. So this is one case where monoclonal immunoglobulin is seen in beta 1 region. All the other fraction looks normal, but there is some distortion in beta 1 region. This can be a monoclonal immunoglobulin or an interference also. To differentiate between interference and again monoclonal peak, we need to run the sample for immunofixation or immunotyping. So additional peak in beta 1 region without iron deficiency. There is iron deficiency, sometimes you can get a peak like. So there is one additional fraction in alpha 2. This can be a monoclonal immunoglobulin again. So to confirm that, we need to run the sample for immunotyping or immunofixation. So how we quantify? First, till now we have identified there is peak, there is no peak, and where is the peak in the graph. Now how to quantify how much amount or how much concentration of that peak is there. So how to quantify that? Because it is useful in the myeloma classification staging of the myeloma. So quantification we can do on the curve. So it will be most accurate. Or by other methods also, nephrometric or turbidimetry, but there are some discrepancies. So mostly on this electrophoresis only, in that curve only we quantify. So this is one screenshot where you can see how we quantify whenever we see a peak. So we drag here like this. So this is the area where we select. The option is there. So by selecting this and we just pull it here from the peak. So this area again, it will show some concentration here. So this is the concentration. So we can name it. So this could be a monoclonal peak with this concentration. So this is how we quantify a peak in electrophoretic pattern. So till now we have seen hypergammaglobulinemia, hypogammaglobulinemia, and monoclonal gammopathies, but there is some other pattern. Usually we see that is oligoclonal pattern. That means it's not a complete smooth pattern in gamma globulin. It's not a single peak, but multiple peaks sometimes we see, or we call it as multiple monoclonal bands. So it's like a oligoclonal profile where we see multiple faint, narrow, homogeneous bands. So usually they are observed in autoimmune reactions associated with transplants or some patients with diseases, rheumatoid arthritis, and in some infections also like viral, bacterial, and parasitic. How the pattern looks in oligoclonal profile is this one. So you can see here the gamma region, it is not smooth. So definitely some more than one peak you can see. So these are the different peaks what we see. So this pattern is called as oligoclonal pattern. So if there is increase in concentration also, we report it as oligoclonal increase in gamma globulin because the number of peaks are more than one. If it is single, definitely monoclonal because it is more than one, two, three. So it is a oligoclonal profile. To know whether it is a oligoclonal profile or not, and what are the different immuno antibodies present and what heavy and light chains are found, we need to run the sample again for immunotyping or immunofixation. So these can be presented in polymerized monoclonal immunoglobulin also, but to differentiate that only we run the sample in immunotyping or immunofixation. Thank you.
Thank you, Dr. Hatim. for your elaborate presentation on the protein electrophoresis. So I'd also like to thank all the participants here, all audiences, those who have come up for this particular presentation. Now I'd like to take some
Not audible.
Sorry. Thank you, Dr. Hatim, for your elaborate presentation.
Thank
And I'd also like to thank all the participants, audiences, for this particular presentation to be here. And I'd like to take a few questions which has come up, and the rest of the questions I'd like to discuss later. So one of the question is like, what is meant by polymerized monoclonal immunoglobulin?
Immunoglobulin look like this, or it can be oligoclonal. How to differentiate means it's nothing but polymerization. Some antibodies like IgA and IgM, the structure they present in the form of polymers. So whenever we run the electrophoresis, they represent like this, but actually it will be a single monoclonal antibody. Why these different pattern appear rather than single monoclonal pattern? Because the structure wise they are bound, they are linked with J chains actually. They are disulfide bonds. So when we run the electrophoresis sample, they represent or they present like this in a different oligoclonal profile. So how to differentiate with oligoclonal profile and polymerized monoclonal immunoglobulin is we treat the sample with reducing substances before running it. So beta mercaptoethanol, one of the reducing substance, where we treat the sample with that so that it will break those polymers into single chains. So when we run that sample again, this will again present as a monoclonal peak rather than these polymerized form. So that is the meaning of polymerization of monoclonal immunoglobulin.
Okay, right. So the next question is, can monoclonal RM spike be seen in other fractions apart from this gamma region, gamma globulin region?
So as we discussed previously also, usually the monoclonal gammopathies, the gamma region, they usually appear, but the monoclonal patterns or the peaks can be seen in beta region also, beta 1, beta 2, and alpha 2. So differentiating with interference and is it an actual monoclonal immunoglobulin, we run the sample for immunotyping or immunofixation. So there are chances that monoclonal patterns can be seen in all the region except albumin and alpha 1. So very rarely we get in alpha 2 beta regions, but we can have a monoclonal pattern in alpha 2, beta 1, beta 2 also, along with gamma region.
Nice. Now, one of the audience would like to know about the interferences in protein electrophoresis.
Okay. Based on the type of sample, so interferences means like if the sample is lipemic or if the sample is lyse or if the patient is having high bilirubin. If we run these kind of samples also, as I said, additional fractions will be seen. So not in these, usually these patterns like albumin, alpha 1, alpha 2, beta 1, beta 2, gamma. Sometimes we get additional fractions or additional peaks in this region. So suppose if the sample is lipemic, that means the patient is having high triglycerides. We'll get an additional peak actually, additional peak in this albumin region. Or if the patient is having some bilirubin high levels. So biliary pigments, when we run this sample, we can get an additional small peak in this area. So that can be due to interference. So that doesn't mean that the patient is having some monoclonal extra pattern or something. So that is called an interference. So likewise, in different regions, we get different interferences. So suppose if the patient is having some hemolysis, the sample is hemolyzed. and we have not seen it, and we run the sample, usually we get an extra fraction in the alpha 2 region because of that haptoglobin and hemoglobin complex. So likewise, if we run the plasma sample instead of serum sample, usually we run serum sample, but instead of that, if we run plasma sample, because of fibrinogen, we'll get extra fraction or extra peak in the beta 2 region. Sometimes we get extra peak in the gamma region because of CRP also. So if the patient is having high levels of CRP, the CRP value should be more than 200 mg per liter, then only those additional fractions will be seen in this gamma region. So how to know it is a interference or not, whether it is a monoclonal immunoglobulin or a oligoclonal profile. So to differentiate with that pathology and with interference, we run the sample for immunotyping. So when we do immunotyping or immunofixation, these interferences will be gone because the anti-sera of antibodies will not react with this. And we can clearly see these interferences will not be reflected in immunotyping or immunofixation. So these are the different interferences we can see in serum protein electrophoresis.
Thank you, Dr. Hatim. And I'd
you.
also like to thank all the participants again for being present for this particular presentation. And rest of the questions, we'll take it later on due to time constraint for this presentation. And with this, we come to the end of this particular webinar. And I'd like to thank again to all of you. Thank you.
Thank you.